Hello, everyone, and welcome to AFTD's educational webinar series. Today's webinar is what you should know about primary progressive aphasia. Our presenter is Dr. Emily Rogowski, Associate Professor at Northwestern University's Feinberg School of Medicine in Chicago. I'm Sharon Demi, Program Director at AFTD, and on behalf of all of us here, I'd like to thank you for joining us today. Before we get started, I'd like to go over a few items to help you participate in today's event. Dr. Rogowski will present her information in 3 parts. Following each part of the presentation, there will be an opportunity for your questions. We ask that you submit your questions by typing them into the questions section located towards the bottom of your control panel. Please send your questions as you think of them. We'll ask as many as possible in the time available. Your microphones will be muted for the duration of the presentation. This allows everybody to hear the presenter clearly. If you have any technical issues, please write a message in the questions box and AFTD's Lauren Gaudier will help you to troubleshoot. Today's webinar is scheduled for 90 minutes. We're recording the presentation and we'll post it on AFTD's website and YouTube channel afterwards. If you find it informative, we'd love for you to share it with others who may be interested in what we're going to hear today. For those of you who are meeting us for the first time, AFTD is a national nonprofit organization whose entire focus is on frontotemporal degeneration. AFTD works to bring help to those affected today and to bring hope for a future without this disease. We do this every day through advancing support, education, research, advocacy, and awareness. AFTD provides resources and support services for people living with any of the FTD disorders, for their families and friends, and the professionals who serve them. I want to call out just a few of the services for you today. Our network of support. AFTD supports a growing network of specially trained FTD group leaders who provide a safe place for people facing FTD to share their support and continue to learn care strategies. Today, 85 volunteer leaders host 75 support groups in 34 states. Partners in FTD Care. This is an educational initiative for professionals and families alike. Dr. Jerry Hall joined us for the fall issue of Partners in FTD Care, which addresses in depth the loss of self-awareness or anosognosia in FTD. Research opportunities. Helping people to stay current with FTD research and to consider participation is one of our priorities. We've recently posted 3 different types of FTD research studies on our featured studies page for people to be aware of. And finally, AFTD's 2019 Education Conference will be in Los Angeles on Friday, May 3rd. We have another exciting program that features national and regional experts in FTD, and registration will open in January. So the best way to stay up to date with these opportunities and all the news from AFTD is to visit our website and sign up for our newsletters. And now it's my great pleasure to introduce our guest for today's webinar, Dr. Emily Rogowski. Dr. Rogowski is a clinical neuroscientist and the associate professor at Northwestern University's Feinberg School of Medicine. She currently serves as associate director of the Mesolim Center for Cognitive Neurology and Alzheimer's Disease and director of neuroimaging at Northwestern University's Feinberg School of Medicine. Her research falls under the broad umbrella of aging and dementia and uses a multimodal approach to investigate 2 aging perspectives. Primary progressive aphasia, in which neurodegenerative disease invades the language network, and superaging, in which individuals are seemingly resistant to the changes in memory associated with normal or more typical cognitive aging. A major focus of her work seeks to improve treatment opportunities for those living with PPA through advocacy, educational programs, and research investigations. We're very fortunate to have Dr. Rogowski here to share her expertise with us today.
Hello, everyone. I'm really delighted to be here today. I'm Emily Rogowski, and we're going to spend the next hour and a half together learning about primary progressive aphasia. We'll talk a little bit about how the diagnosis is made, what we know about PPA or primary progressive aphasia, the research that's been happening, and its relevance to both care and treatment. So as we begin, I wanted to just introduce our center just a bit. So I'm at Northwestern University, and we're part of an NIA, or National Institute of Aging, funded Alzheimer's Disease Center. And you may be wondering why I'm telling you about that, but I'm telling you about it because even though it says Alzheimer's Disease Center, it actually covers Alzheimer's disease and related disorders. So primary progressive aphasia comes underneath that umbrella. We're one of 32 nationally funded Alzheimer's disease centers. And up here you'll see a map of the United States that was put together in 2014 showing the active Alzheimer's disease centers across the country at that time. And in this research study, what they did is, so each of the red dots represents an Alzheimer's disease center, and what the dots are connected by a number of lines that kind of look like flight patterns, but instead they actually represent the way that we collaborate with each other. And one way we do that is to write scientific papers. And so the numbers of lines, or the thickness of those lines, represents the number of the proportion of papers through those collaborations. So as an Alzheimer's disease center, we do some things that are identical, and that is that we find individuals in the community and we ask them to come and participate in our research. We are looking for both healthy individuals and individuals with a diagnosis of dementia. So it could be Alzheimer's dementia, it could be primary progressive aphasia, it could be one of the other FTD disorders. So we're collecting information, and then we're collaborating, and then ultimately the goal is to translate that information so that we better understand and can move towards a treatment for Alzheimer's disease and FTD disorders and other related dementias. So each of our centers, we do some things that are identical, but then we also do some, we're also allowed to have a little bit of personality, so we can have areas of focus. And at our center, one of our areas of focus is on primary progressive aphasia research, and I'll be able to tell you a little bit more about that research program as we go along. So to start off, a question that commonly comes up is it primary progressive aphasia or dementia? Or my loved one has primary progressive aphasia but not dementia. And so it sort of brings to light how confusing the terminology can be. And so I want to kind of clear that up a little bit in this presentation and make it clear how I think about those two terms. So we think of dementia as a clinical term for the loss of memory or other thinking skills. And that loss is so prominent that it significantly interferes with one's daily life activities. So this really represents a change in memory or other thinking abilities, including language. And then there's several different causes of dementia. And the first four that I have up here, vitamin deficiencies, medication side effects, and other medical conditions, and excessive alcohol use, can cause the symptoms of dementia, but these are potentially reversible. So if you correct those vitamin deficiencies, then those memory loss or other thinking skill deficits will go away in many cases. Now there's a fifth category, and that's neurodegenerative disease. This is the umbrella under which primary progressive aphasia fits. So to put this another way, we think of dementia syndromes caused by neurodegenerative disease as the big umbrella term. So that's the umbrella term. And then underneath that umbrella, there's different types of dementia syndromes. So there's Alzheimer's dementia, where there's memory loss that occurs and is going to get worse with time. There's another type of dementia syndrome called posterior cortical atrophy syndrome, and those individuals experience difficulty with visual spatial abilities. There's the behavioral variant, frontotemporal dementia. These individuals have changes in behavior and judgment. And then finally, primary progressive aphasia. So this represents individuals with language difficulties. The four examples underneath this umbrella these are not an exhaustive list of all of the different types of dementia syndromes, but just to give you a flavor, the idea here is that dementia is the big umbrella term, and then there's different types of neurodegenerative dementia. So when we still think about terminology, it's easy to get confused. And I think one of the really lovely things that Dr. Mesulem did when he first described primary progressive aphasia in the early 80s is that he actually built the definition right into its name. So if we work from the bottom up, we know that there's an aphasia, so there must be a language impairment. And then that aphasia must be progressive, so the impairment is going to get worse over time since it's caused by a neurodegenerative disease. And then the word primary refers to the fact that early on that the deficit is residing in a single domain, in this case language, and that there's relative sparing of other abilities such as memory, personality, and perception. So how is that diagnosis of PPA made? So it's very different. The diagnosis of PPA is different than when you go to the doctor with a sore throat and you say, oh, I wonder what this is caused by, and the doctor gets suspicious about strep throat, and they'll do a quick swab, and in 5 minutes you have a result back telling you whether you have strep throat or not. The diagnosis of PPA is much more complex. And as many know, it can be a long and tedious process because the awareness about how to make the diagnosis and clinician awareness about the syndrome is low, but getting better. We think about the diagnostic process as a ruling in and ruling out process. So it has several elements. An important element is the medical history from the client and the family members, and that really is an essential part of the diagnosis to understand how did those symptoms start to occur. Did the individual wake up one morning and suddenly have difficulties with language, or is this something that occurred more slowly with time? When it occurs more slowly with time, then the clinician is going to be more suspicious about a diagnosis of PPA. There's a neurological exam that will occur as a part of the diagnostic process, and that's a both ruling in and ruling out process of other causes of dementia or other causes of the symptoms. And then a neuropsychological assessment to really figure out where are the strengths and weaknesses of that individual. So are those challenges isolated to the domain of language? Are there also challenges with memory and other thinking skills? And then there are certain laboratory measures that can be useful for ruling in and ruling out. And we'll go over those as we move along here. Another important thing to remember is this idea of a clinical diagnosis versus a neuropathologic diagnosis. When we use the word clinical diagnosis, there we're referring to the symptoms. So in this case, for PPA or primary progressive aphasia, we're talking about language deficits would be the symptoms that the individual experiences. And so for an individual who experienced memory loss, Alzheimer's dementia would be the clinical diagnosis. When we think about the neuropathologic diagnosis, here we're talking about the bad protein that is causing the symptoms. In the example of Alzheimer's dementia, most of the time, the neuropathologic diagnosis is Alzheimer's disease. So the memory symptoms are caused by Alzheimer's disease, and to have a diagnosis of Alzheimer's disease, there must be an abundance of amyloid plaques and tau tangles in a certain distribution. This neuropathologic diagnosis is currently made and can only be confirmed after death by autopsy. So if we transition now to primary progressive aphasia, you're going to see that the neuropathologic diagnosis is much more complex. Instead of one common diagnosis, there are actually 3 different options, and I called them families in this presentation. So about 40% of the time, individuals with primary progressive aphasia have those same plaques and tangles that is seen in Alzheimer's dementia, but they tend to be more in the language parts of the brain than in the memory parts of the brain. So the individual has language deficits rather than memory deficits. The next family is called frontotemporal lobar degeneration, or you may see it as FTLD tau. And then the third family is frontotemporal lobar degeneration caused by TDP43. So when an individual walks into the clinic, they may receive a clinical diagnosis of primary progressive aphasia. And we currently have no definitive way of understanding whether that individual has Alzheimer's disease, FTLD tau, or FTLD TDP43. But we're working on a lot of biomarkers that will help us serve kind of as that strep test to figure out during life which disease or bad protein is causing those language deficits. So if we move back to this diagnostic process and the ruling in and ruling out, another part of that process is laboratory measures. So blood tests are used primarily to rule out other causes of the symptoms. So we talked about at the beginning that vitamin deficiencies could mimic the same changes that happen in neurodegenerative disease. And so we want to, the clinician will make sure that we'll use blood tests to make sure there are not other things causing those symptoms. Another thing that might be helpful is a lumbar puncture, and here they're examining the cerebral spinal fluid, and it can give us a proxy measure of the health of the brain by doing this, and it can be useful in understanding what the likely neuropathologic diagnosis might be. And we'll show you an example of this in just a bit. Structural MRI or imaging measures can also be useful in the ruling out and ruling in process. So if an individual has language deficits, the clinician would want to make sure that there was would rule out other causes for the symptoms, such as a tumor or a stroke. And to rule in, they would look for things like atrophy or brain cell loss in areas consistent with the symptoms. So in this case, they would look for atrophy or brain cell loss in the language parts of the brain. Another type of imaging is called PET imaging, and there are 3 different types of PET imaging that might be used. The first is called metabolic PET, and so this is looking at glucose activity in the brain as a proxy measure of how active the brain is, and the clinician would be looking for changes again in those language areas of the brain. Amyloid PET is a newer ligand and primarily used in research, although it has been FDA approved and can be helpful for determining what the likely underlying pathology is or is not. Tau PET is only used in research right now, but it is measuring the amount of tau, or the bad protein tau, in the brain. And we're currently trying to understand how it might be useful and its reliability in helping with the diagnosis and prognosis over time. So if we look at these biomarkers, now here's an example of what one might see. So on the top, you'll see patient A has had an amyloid PET scan, and the bright red colors signify that there's elevated amyloid. So now the clinician would be suspicious that Alzheimer's disease was causing the symptoms. And if you look on the right, this asterisk here represents the CSF measures that were done, and we'll see that this person's values fall within a range that is consistent with Alzheimer's disease. So if an individual with primary progressive aphasia had a positive amyloid PET scan and CSF levels that were consistent with Alzheimer's disease, the clinician would be most suspicious that the neuropathologic diagnosis would be Alzheimer's disease, and the clinical diagnosis would be primary progressive aphasia. On the bottom, you'll see another amyloid PET scan, but this time there's not as much red. And you'll see that the CSF markers are now not consistent with Alzheimer's disease. So the clinician in this case would be able to rule out, they would be less suspicious about Alzheimer's disease causing these symptoms and more suspicious about one of the other forms of frontotemporal lobar degeneration causing the symptoms for primary progressive aphasia. I thought it might be helpful to kind of compare and contrast PPA to Alzheimer's dementia. So when we look across the two, we see that the clinical symptoms are different. So there's language loss in primary progressive aphasia and memory loss in Alzheimer's dementia. We know that Alzheimer's dementia is the most common neurodegenerative dementia, and that primary progressive aphasia is less common. When we look at the distribution by gender, in Alzheimer's dementia, there's a bias where more women than men tend to experience these symptoms. We don't see that same gender bias when we look at primary progressive aphasia. The distribution is relatively equal between women and men. The age of onset differs between these two clinical dementia syndromes. Individuals with Alzheimer's dementia tend to be over the age of 65. Individuals with primary progressive aphasia tend to be under the age of 65. And this brings some unique challenges as far as the life stage that the individual is in and where they may be as far as raising a family or working compared to individuals with Alzheimer's dementia. The majority of the cases are sporadic in both primary progressive aphasia and Alzheimer's dementia. Insight, so understanding that these symptoms are occurring, tends to be intact for individuals with primary progressive aphasia, where individuals with Alzheimer's dementia may have compromised insight, so they may not be aware that they're forgetting. The risk factor profile seems to be different between individuals with primary progressive aphasia and Alzheimer's dementia. So age is the biggest risk factor for those with Alzheimer's dementia. And ApoE, having at least one copy of the E4 allele increases one's chance of developing Alzheimer's dementia. It doesn't guarantee it, but it increases the chance. ApoE doesn't seem to have that same effect for primary progressive aphasia. So if we just stop and kind of review what we've done so far, we have the symptoms or the clinical syndrome of primary progressive aphasia, where there's changes in language and relative sparing of other thinking abilities. We know that those changes occur because of atrophy and cell loss in the language parts of the brain. And so those are highlighted here in this sort of purplish blue color of the brain. This is as if you're looking at the side of the brain. This would be the front, this would be the back, and your ear would be about here. And then neuropathologically, we know that there is no one PPA disease. Instead, there are 3 families of disease that can cause primary progressive aphasia symptoms. Alzheimer's disease, FTLD tau, or FTLD TDP43. So you might be wondering, well, what do all of these neurodegenerative diseases have in common, or do they have anything in common? And one way to think about this is they all represent bad proteins. So a normal protein has a certain way of folding. And so I represented this here in a simplistic way as kind of like in this origami elephant. So this would be the correct protein folding, or a normal protein folding. But what happens in neurodegenerative disease is that that folding becomes abnormal or misfolded. And when it becomes abnormal and misfolded, it also becomes very sticky. And so it does something called aggregation, or it attracts other abnormal proteins. And so there's this aggregation of bad proteins. And that's what leads to neurodegeneration or damage to the brain cells. If you're familiar with primary progressive aphasia, I'm going to go back now to the clinical symptoms. You may have heard about PPA subtypes. I think about these as a work in progress. So there's a research framework that has been proposed about, and there are 3 different recognized subtypes of primary progressive aphasia. One is called the semantic subtype. These individuals have difficulty with word comprehension, but they have preserved grammar. There's an agrammatic subtype. These individuals have preserved word comprehension, but impaired grammar. And then the logopenic subtype describes individuals who have preserved grammar, preserved word comprehension, but difficulty with word finding and retrieval of words. And they have impaired repetition, at least some of the time. So while this framework was helpful in many ways of thinking about the cluster of symptoms that tend to hold together across individuals, I call it a work in progress because as we know, we're all individuals, and it turns out as individuals, we don't always fit neatly into these bins. And with research over time, we've found that even 40% of the individuals with PPA wouldn't fit into one of these 3 bins. One of the reasons that the subtyping idea gained some excitement or interest was that we found that there was unique patterns of atrophy that were associated with these symptoms and these different subtypes. And initially, there seemed like there was a mapping between the subtype and the likelihood of pathology, so that the logopenic subtype tended to be Alzheimer's pathology, the agrammatic subtype tended to have FTLD tau pathology, and individuals with a semantic subtype tended to have TDP43 pathology. And while each of these subtypes do tend to have a little bit higher association with each of these types of pathology, the real picture looks something more like this, so that there's no one-to-one correspondence between the clinical subtype and the underlying pathology. And we're moving now to a place where we're trying to identify specific biomarkers to understand which bad protein is causing the disease for each individual. So it's important to remember, and we now know that the experience for someone with a diagnosis of PPA is unique for each individual. And it's unique on several different levels. There's individual variability in the initial symptoms that an individual might experience, the emergence of new symptoms. Because it's a neurodegenerative disease, the disease doesn't stay still in the brain, and so as it moves, and depending on the direction that it moves in the brain, individuals may experience new symptoms. So there may be changes in memory that occur, or changes in judgment that occur over time. The rate of decline and life expectancy are quite variable at the individual level. Life expectancy can range from 3 to 20 years, and for some individuals that means their decline is much more rapid than others. This is a very important area of research to understand which things are driving that rate of decline, and so that we can improve prognosis information for individuals at the individual level for families. There's also individual variability in how PPA impacts one's daily life activities. So we kind of think of primary progressive aphasia as this moving target, and we have to consider all of this individual variability and how we can, and that has to be an important part of how we develop care plans and management of the disease over time. So at this point, we'll take our first break for questions, and then we'll start with the second section after that.
Great. Well, thank you very much, Emily. It's wonderful to see how you're laying out and walking people through kind of that process, moving from the big umbrella of dementia to the different types of dementia, and then down even to a more granular level with different types and different subtypes of PPA. In terms of getting a diagnosis, can you actually start from the point where people are discovering changes in language that they might have identified with a family member, kind of the trajectory early on, what it looks like for finding the optimal path to getting a diagnosis of PPA, and then I'll ask you additional questions from there.
Sure. So I think the path, unfortunately, tends to be different at this point in time for different individuals. But ideally, as awareness and advocacy grows, and we really have seen a lot of those changes happen so that there is more recognition of these atypical dementia syndromes, so that an individual may go and talk to their primary care physician, and when they describe these changes, it really is most appropriate that they go to see a specialist, and that a specialist would make this diagnosis. In our center, we have a team of specialists, and we'll talk about this a little bit more as we go on with the presentation, but you would come to see a neurologist or a neuropsychologist, and we also have a social worker who gets involved in both the care process and the diagnosis.
Perfect, thank you. One of the folks that, so I will hold off on some of the other questions about subtypes and moving into the identification of the subtype, but one person was asking if you could please clarify what APOE is.
Sure. So APOE is a gene, and everybody has 2 copies of the allele. So you can either, the flavors are 2, 3, and 4. And everybody has a pair, so you can either be 2, 2, 2, 3, 3, 3, 3, 4, 4, 4, and so on. And if you have 1 copy, so you get 1 copy from your mom and 1 copy from your dad, and if you have 1 copy of the 4 type, then it increases your risk for Alzheimer's disease. But it doesn't seem to do that same thing for individuals with PPA.
Great, thank you. So when people are going through that path to a diagnosis and they may be diagnosed with PPA, they're able to see a specialist. The evaluation would continue and drill down a little bit closer. Can you be diagnosed with one of these neurodegenerative diseases or even one type of PPA, and then other diagnoses come into the picture later on?
Sure. So if you get the initial diagnosis of PPA, so that clinical diagnosis would represent the fact that initially your symptoms started in the domain of language, and other abilities were relatively spared. If that diagnosis occurs, then there would be kind of those 3 different families that could be causing it. And if we used some of those imaging or other biomarkers, we might be more suspicious about one of those neurodegenerative families over another. But the definitive diagnosis at this point still requires looking under the microscope after an individual passes away at their brain tissue. Now, if we, with time, the symptoms that an individual will experience, because it's a neurodegenerative disease, will change. So an individual may start with language deficits and then have problems with memory that emerge with time, or problems with, or changes in personality or judgment that may emerge with time. the clinical diagnosis of PPA would remain in that situation, but we would describe the individual based on the symptoms and challenges that they were experiencing, and their care that they receive would reflect those changes, ideally.
So can you talk a little bit more about the clinical symptoms? And you did mention how the different subtypes of PPA have sort of overarching differences, but especially when it comes, I know that we talk to a lot of folks here who maybe are diagnosed with PPA and they see some changes in language, but they're not seeing them necessarily the way that you're parsing them. Can you kind of speak to the, what would people see that go along with semantic PPA or logopenic or agrammatic?
Yeah, so, and I think this is why I say the subtyping scheme is sort of a work in progress, and it may really make a lot of sense. It's something that really is primarily used in the research realm and is not really perfected yet for general use. And I think it's more important to talk to the individual and really understand where are those strengths that they still have, where are the challenges. So does the individual have difficulty following along in a conversation? Do they still, if you said a word, would they understand what that word meant? Individuals may have difficulty thinking of words in conversation. Some individuals may have trouble naming items or remembering the names of people or objects. Individuals may have difficulty when they speak. They may leave out certain grammatical words. And so these are all symptoms that can occur. But the symptom that people report most commonly initially is that symptom of word finding. So they can't think of the words that they want to say.
Great, thank you. I'm going to jump around a little bit, so come along with me as the questions come in from our audience.
Sounds great.
Can you explain what sporadic occurrence means?
Oh, okay, sure, certainly. So when we think about genetically, so most of the cases of primary progressive aphasia, there aren't other family members who have experienced those same changes, and for the most part, it's rarer if it's caused by a dominantly inherited gene. So these are not, most of the cases of PPA are not caused by one genetic abnormality.
So most of the cases of PPA are, in this context, sporadic means not caused by an identified genetic mutation. There are some people who have a familial inheritance of PPA. Does that vary by subtype, or can you just say a little bit more about that?
Yeah, so it's really less common that it's inherited, and there are kind of 3 genes that have been identified for those unusual cases, and 2 of them are on chromosome 17. One is MAPT, the other one is granulin, and then there's one on chromosome 9, which is called C9orf72. So there's no need to really remember each of those names. If you were suspicious about whether the PPA was caused due to one of these variants, it would be more likely that you had a strong family history, so that you saw it for several generations or within your sibling and children pairs.
And I'm thinking of your slide, Emily, where you had all the lines crossed among the different subtypes. And it seems as though the complexity of these disorders is a really underlying theme, both in terms of the diagnostic process, understanding where there may be some familial inheritance if there's a pattern in the family already, but that idea that things don't necessarily map one-to-one in terms of the underlying disease, and then also clinical symptoms, and then at that other level, then to some extent genetics as well. The complexity, I think, is why the research and the work that you're doing at Northwestern is so important. and why opportunities for people to continue to learn about the diseases and kind of move their way into that understanding as they're able is really valuable. A couple other questions before we move on to the next section of your presentation. Can you explain a little bit more about the significance of CSF fluid?
Yeah, so when you get a lumbar puncture, we're able to pull out CSF, and we can look at protein levels in that CSF, and that can give us a measure of, because the CSF is continuous with the CSF that with the fluid that is around your brain, that your brain in our skull sits in fluid, and by measuring the protein levels in the CSF of the spinal cord, we can get an idea of the healthy protein levels in the brain. And so if you remember, we had the graph up with like the pink quadrant and the green quadrant. So we've identified levels of that are associated with the diagnosis of Alzheimer's disease neuropathology versus other pathologies. So the CSF is useful for helping us determine or ruling out certain neuropathologies as the cause for the symptoms.
So in this particular case, someone had a spinal tap, a lumbar puncture, as part of the evaluation process. Their loved one did, but they did not get information from the results of that at the time. Is that valuable information to request afterwards, after completing the diagnostic process?
Yes, that would be valuable information. I guess it depends on whether it's done in a research context or if the CSF was taken in the context of a clinical evaluation. But if in a clinical evaluation, it certainly is worth understanding what those values were.
Great,
so it'll become even more valuable when we have the perfect treatment, so that we make sure that the individual who has PPA due to Alzheimer's disease is getting the Alzheimer's treatment and not the FTLD tau treatment.
Right. Do you find that overall observations of the caregiver to be a critical part, a critical adjunct, or a critical part of the evaluation process?
Certainly. So that's even why that it's the first thing that I listed sort of in the how is the diagnosis of PPA made. It's both that medical history and the information from the person experiencing those symptoms and the information from the family. It's really important that we understand whether these symptoms occurred very overnight, very quickly, acutely, or if there's something that's developed over time, and to really understand in which settings the individual is having difficulty with language and what types of language output or understanding of language the individual is having challenges with.
Thanks. We've got a couple of questions related to logopenic PPA specifically. And in part, I think people are wondering, so is logopenic PPA syndrome is it an atypical form of Alzheimer's disease? Is it really PPA? Can you speak to how you understand logopenic PPA?
Sure. So to receive a diagnosis of logopenic PPA, there's a stepwise process. So first and foremost, that individual needs to have a diagnosis of primary progressive aphasia. So we call that the root diagnosis. So that's step one. And then from there, we would you could look at what subtype an individual has. It seems like the research data that we have so far suggests that individuals with logopenic PPA are more likely to have those symptoms due to Alzheimer's disease than to one of the other families of neurodegenerative disease. However, there's no one-to-one relationship there. So individuals with logopenic PPA do not always have Alzheimer's disease as their neuropathology.
More points in the complexity of the disease.
More points, yes.
Maybe we'll do one more question here and then move on. How often should people consider repeating PET scans, and what would prompt a repeat PET scan? So
repeat PET scans are mostly done in the context of research right now. So for example, in the tau PET scans, we think that there's good evidence that suggests that the tau PET scans may show us how the pathology is accumulating over time and may be a better predictor of symptom progression than the amyloid PET scans. But this is really an area in its kind of infancy of research, and what we learn about its utility will inform clinical practice eventually. So I think it's too early to tell the precise guidelines of how frequently the scan should be repeated from a clinical standpoint. Part of the reason a clinician may ask for a repeat scan would really depend on that individual's symptoms and profile and understanding of their individual case.
Great, thanks. I'm going to actually slip in one more question because I think it's an important one that we know causes confusion for people. There's a lot of confusion around the language that we use in these disorders, and parsing that and helping to clarify that is always really important. So this particular question goes to the relationship between PPA and FTD. So does a person with FTD also have PPA if their language deteriorates? Is the question that came in. But I think what I'm going to ask you is, can you go back to the beginning of your presentation and place PPA in the context and under the umbrella of frontotemporal degeneration disorders?
Sure, sure. So sometimes PPA is described under the umbrella of frontotemporal dementia. And the idea is then there's two variants of frontotemporal dementia. There's a language variant and a behavior variant. And the reason for that nomenclature is, or that name, the way that term is used, is because in frontotemporal dementia is actually describing where in the brain the damage is occurring. So it's happening in the frontal lobes, which are, as the name implies, towards the front of our brain, and then the temporal lobe. So maybe what I can do is go back to a picture here quickly. So if we look at this picture, this is your temporal lobe of your brain, and then there's changes that occur in the frontal lobe. So that's where that nomenclature kind of comes from, is this idea that there's damage in behavioral variant FTD in the frontal and temporal lobes, but in a slightly different distribution. And in primary progressive aphasia, the language parts of the brain are also in the frontal and temporal lobes. So another way to describe this is when we think about real estate, if you're a real estate buff, they always talk about location, location, location. So the same is true for clinical symptoms. The clinical symptoms that occur depend on the location in the brain in which they happen.
Great. All right, let's move ahead in the rest of your presentation.
Sounds good. Okay. So the next part, we're going to transition to treatments, care, and research. And we're going to divide this into two parts. And to begin, and when we start to think about care, you might wonder, well, who should be providing the care? And is it just one doctor or many doctors, or really who should be a part of that care team? And that's how we like to think about it, is as a care team. And I mentioned earlier that at our center, we have neurologists, neuropsychologists, social workers, and also speech-language pathologists that work together as a team. And those might be familiar to you as the team that can work together. But there are many, many, many other people who will be essential elements to your care team. And some of them may come in later on throughout the course of the disease, and others may be more helpful early on. And so this is not an exhaustive list of the care team members that might be important, but it is a good start of a list that might be useful. And the critical element here is that there's communication among these interdisciplinary team members, so that they're talking to each other and that there's information transfer. So the left hand is talking to the right hand, so that there's real coordination in that care. When we think about care, it's important to remember who needs care. So it's not just the diagnosed individual, but when you have a diagnosis of PPA, there's incredible variability in how it's going to affect individuals, and it changes both the family and family relationships. So for the person, there's a loss of independence. There can be social isolation and exclusion. There can be loss of a meaningful occupation, concerns about the future, and significant emotional impact. And questions about, self or identity. For family, there can be a number of challenges in understanding how the finances are changing, as well as physical and emotional challenges. Because the diagnosis of PPA tends to occur in individuals under the age of 65, for some families, there's younger children who are still living in the home, that individuals may be in the prime of their career. So these are, when we think about care, it's not only about the individual, but really thinking about all of these different biopsychosocial considerations. So what do we know about treatments? So currently there's no cure, but this is really an active area of research, and I think it's a time to be very hopeful. And I'll talk to you a little bit about that hope and that research in just a moment. But the other thing that might be helpful in the realm of treatments is that medications might be helpful with particular symptoms that an individual with primary progressive aphasia may experience. So depression can be common and may be helped by medications, anxiety, trouble with sleep, other symptoms like that. And just because there's no cure, that does not mean that there's nothing that can be done. And so we'll talk about non-pharmacological treatments in a little while. But at first, I want to just talk a little bit more about the hope that exists. And as researchers, we're excited in one way to talk about how PPA research has really grown over the last 18 years is to look at the number of scientific papers that have been published. And so that's what this graph shows, is how there's really been an increase in the number of scientific papers. And in addition, there's been an increase in resources and advocacy. And so this is just a subset of the groups that are currently advocates or research programs related to primary progressive aphasia and frontotemporal dementia. And many of these really weren't even in existence in the year 2000. So I think it's a real time of excitement and hope. And because of this advocacy and interest, we've seen some exciting discoveries in the last few years. So just to highlight a couple of the national and international consortium that are out there. So there's the longitudinal evaluation of frontotemporal dementia subjects, also known as LEFTES. And then ARTFUL is kind of its sister project. So LEFTES is for individuals who have a familial history of PPA or FTD, where ARTFUL is for individuals who would fit under that sporadic diagnosis of primary progressive aphasia or FTD. And these are observational studies that are helping to figure out the best way to construct clinical trials in this population and to learn about the progression rates and how we can improve our understanding of prognosis at the individual level. GENFI is a study that actually came about before ARTFUL and LEFTES, and it was initiated as a collaboration between Europe and Canada. It again is looking at individuals with genetic forms of FTD and is observational in nature, and again preparing us for the development of new treatments and how those clinical trials might be run as new treatments emerge. You're all on the webinar that's run by the AFTD, so hopefully you're aware of the FTD Disorders Registry. That's another opportunity to participate in research that might be a little bit lower burden. So you can join the registry without having to go into a clinic or come in for an evaluation. So that's pretty simple, and that's a good way, again, for us to learn more about the experience of individuals that people experience with PPA and FTD. So I highly encourage people to look into this registry if they haven't already. At Northwestern, we're involved with the Artful and Lefties program, but we also have a program that's specifically focused on primary progressive aphasia. And we've been funded for this program for over 10 years now, and we recruit individuals from across the country and fly them in to participate so that we can better understand the features of language change that individuals are experiencing. We really want to understand risk factors, disease progression. This study is teaching us about how language is organized in the brain, and we're looking for new genetic markers and understanding how neuroanatomy or the brain atrophy is changing with time as well. So we've currently enrolled over 150 participants from 33 states, DC and Canada, and if you're interested in participating in this research, our website is listed below, and we'd be happy to talk to you about that as well. So I thought I'd just highlight some of the ways that research participation has led to new discoveries. And one of the things that we do in my laboratory is we look at MRI scans and quantify the changes that are happening in the brain. And so what happens is an individual gets a MRI scan of the brain, and we process it through a fancy computer program that labels the outside, the outermost edge of the brain. So now it's as if you're looking, as if I cut open, you're looking forward at someone's brain, and this is one side of the brain, this is the outermost layer, and then it also labels what we call the gray-white junction. And what we're interested in as researchers is the distance between these red and yellow lines here. And what that gives us is a measure of what's called the gray matter, and that's where our brain cells live, and it gives us a proxy measure of the health of the brain, and so we can measure how much that changes over time or changes initially compared to what an average individual who wasn't experiencing these symptoms would have. And we're able to get maps like this, where again, this is the front of the brain, this is the back of the brain. It's as if you're looking at the side, your ear would be about here. And the red and yellow coloring represents areas of atrophy or where brain shrinkage would occur. And we've used this method to understand about many things related to primary progressive aphasia. Most recently, we've really changed our understanding about where word comprehension may be in the brain. So there's years and years of thinking that something called Wernicke's area, or the area for understanding words, really resided back here in the brain. And part of the reason that we thought that is most of the evidence came from individuals who had language deficits due to stroke. And it turns out that when there's certain areas of the brain that are more vulnerable to stroke than others, and that this area of the brain is not commonly damaged in stroke. And so when we look in individuals with PPA, we get a whole new understanding of where word comprehension or the understanding of words might reside in the brain. And so this is a recent publication by our group showing that we learned that understanding sentences as brain ranges important for that are the ones highlighted in green, where understanding words are highlighted here in yellow. Another thing that we can use these brain scans for is providing fundamental knowledge about disease course, informing prognosis, and identifying potentially useful metrics for clinical trials. So in a clinical trial, it's important to have identify which measures you're going to use to show that the drug is either working or not working. And one metric to do that could be if an individual has less change in, less shrinkage of their brain over time when on the medication. We're learning from this picture on the right that individuals who have PPA, likely due to Alzheimer's pathology, may show a different pattern and rate, or a greater rate of atrophy than individuals who have PPA that is not due to Alzheimer's pathology. This is still kind of early understanding, but these are the types of studies that we're doing to improve our understanding of prognosis. So you might also wonder, well, how is this information disseminated, or how would I learn about this research, and how do researchers share this information with other researchers? And so we do this through a number of ways. One is through scientific publications that are sometimes picked up in the popular press or media. Another way we do it is by getting together for conferences to share ideas. And some of these conferences also have components that are open to the public. And so I thought I'd share some of these with you right now. So just this past month in November, there was the International Conference for Frontotemporal Dementias that was held this year in Sydney, Australia. And this conference is held every 2 years, and as the name suggests, it's an international conference, so we get together with all of the other FTD researchers across the world and share our newest findings. And so we've just done that, and now 2 years later, we will get together in Minneapolis in 2020, and from October 7th to the 10th. So if you like to plan far ahead, this is something to put on your calendar if you're interested in this area. And there is a day dedicated for care partners as well. So it's not just the scientific researchers that are getting together. Of course, as was mentioned in the beginning of this webinar, the AFTD Education Conference is another great way to learn about the newest research happening in this area and to find education and support. And that will be held in Los Angeles this May. Los Angeles is a popular place this year for conferences. The Alzheimer's Association International Conference is also held in Los Angeles this July. And just like the word Alzheimer's Disease Center that we talked about earlier, just because it's the Alzheimer's Association Conference, the Alzheimer's Association covers both Alzheimer's disease and related dementias. So primary progressive aphasia and FTD research is covered there as well. The National Institutes of Health also holds research summits, and each year, as a part of the National Alzheimer's Project Act, which covers Alzheimer's disease but also related dementias, there's a mandate to hold these summits. And coming up this spring will be the summit that is held on Alzheimer's disease and related dementia. So FTD and PPA will be more prominently featured in that one. And then the following year will be the Research Summit on Dementia Care. So at this point, we'll stop again to take some questions, and then we'll focus on some more research after that about non-pharmacological treatments.
Great, thank you. So one question is related to actually bringing in a different aspect of clinical experience, but learning disabilities. So is there any research currently linking people with learning disabilities as a predisposition or a risk for developing PPA?
Sure, actually, yes, that's a great question. That's research that came out of people who participated in the studies here at our center. So what it seems like is that learning disabilities may be a risk factor for primary progressive aphasia, but let me unpack that a little bit. So it's not that every individual who has a learning disability is likely to develop primary progressive aphasia. If that was true, then there would be many, many more individuals with primary progressive aphasia. Instead, we think that we see a higher prevalence of learning disabilities in individuals with PPA or their first-degree family members than we do in other dementia syndromes or in the general population. And so the the critical point here is that the hypothesis is that if an individual was destined to get a neurodegenerative disease, and that disease was shopping around in the brain of where to target first, it's going to go to an area that's most vulnerable. And we think that learning disabilities may make the language parts of the brain more vulnerable and more appealing for that disease to settle in that location first. So let me give one more analogy. If you twist your ankle, you are more likely to twist that ankle again than you are to hurt your wrist or your arm. So there's sort of some weakness there, that there's a vulnerability, and that's how we sort of think about learning disabilities at this point.
Great, thanks. Are there any drug trials that are currently underway or coming into the pipeline with promise for slowing down PPA?
There's a lot of preparation for drug trials, and there are a few drug trials that are underway for individuals with those genetic forms of FTD, and there's also Alzheimer's drug trials that may be appropriate for individuals with primary progressive aphasia who have biomarkers that suggest that Alzheimer's disease is causing their primary progressive aphasia. So I think we're hopeful that that landscape will change in the near future, but there's those are really those are the opportunities right now.
So is it fair to say, Emily, that there are compounds coming into the realm of clinical studies, but the key really in all of those studies is what you were saying earlier on, which is understanding and knowing the pathology that's causing the clinical symptoms becomes really important here. So somebody who may have a clinical diagnosis of PPA, this is actually, you know, their eligibility for studies of different compounds as they emerge has to match with the particular type of pathology that might be causing those symptoms.
Exactly. So, and this is something that there have been clinical trials done for individuals with primary progressive aphasia in the past. And this is one of the things that we think hurt the outcomes of those clinical trials, because down the road, as those individuals came to autopsy, we figured out that their pathology wasn't the same across the group. So it's really critical to come up with these biomarkers so that we give the right individual the intended right drug to figure out which one is working.
So a related question is, what would you say that the single most important thing for someone with PPA, specifically logopenic PPA in this case, what's the most important thing they could do to slow down the rate at which their abilities deteriorate?
So I think we'll touch on this a little bit in the next session, but I think the first part is building that care team. The next thing that I would personally recommend is talking to, getting social workers involved and getting a speech language therapist involved, so they can be quite helpful in coming up with strategies to really maximize an individual's skills and try to give you tools to optimize your quality of life and your abilities.
Great. And I have one more question before we move on, and it's a little bit different, but the question is that if somebody has a diagnosis of PPA and it's known to be linked to tau protein and PIX bodies, does that affect the risk of their potential risk for having a familial inheritance of the disease?
Well, yes, I guess it depends on how they know that. And so that's something certainly to talk with their specialist about, and potentially a genetic counselor if there's that family history within their individual family. So that's an important conversation to have with their care team.
Great, thank you.
Because they may be particularly eligible for one type of clinical trial over another.
So that is actually an example where knowing the protein or knowing the pathology could be helpful if there was an interest in participating in studies. And the answer, again, regarding the potential risk for inheritance goes back to that complexity, that there's no one-to-one correspondence within these diseases. So being able to kind of articulate with the care team and with the physicians and others involved what those questions are and how can you get to the answers that people are looking for, because it's not a straight line. So,
absolutely.
Well, let's move ahead, and then we'll still have ample time at the end to pick up with any additional questions that people have or want to send in to us.
Okay, sounds good. All right, so we saw the beginning of this slide earlier, that there's currently no cure and that medications may help with symptoms, but now let's kind of transition to think about non-pharmacological interventions. And so that's just a fancy word to say non-drug intervention. So what things might be helpful for individuals with primary progressive aphasia, what kind of things have been tried. And so we see that art therapy is something that has been useful for some individuals. Music therapy is another thing that individuals, there's been a little bit of research on. Support groups in speech language therapy are the two that I'll kind of highlight today, and so that's why they have little asterisks next to them. And just want to highlight that the picture shown here is actually artwork done by an individual with a diagnosis of PPA, and it's just really lovely. So at our center, we've run a number of different types of support group models and found them to be successful. We've run traditional support groups. We've run support groups that had an educational component at the beginning, followed by a more traditional support group. We've run activity groups, and we've run these groups for individuals caring for someone with primary progressive aphasia. And then we've also run the activity groups in particular for individuals with a diagnosis of primary progressive aphasia. And you might think at first, well, that doesn't make much sense to have a support group for individuals who have difficulty thinking of words in conversation, and that might be kind of mean. But actually, this was something that was suggested by an individual who had a diagnosis of primary progressive aphasia, and they really wanted to meet other people with this diagnosis and learn from them and be in community with them. And we found that to be very powerful and actually really successful. We've also tried an online support group for individuals with a diagnosis and their care partners. And so that's what's shown here on the right. And the way that we ran this is we started with an educational component, and then we asked the care partners or communication partners to leave the room, and the individuals with a diagnosis of primary progressive aphasia had a traditional support group and shared for a period of time, and then we flip-flopped and asked the individuals with a diagnosis to leave the room, and then the care partners got the opportunity to meet each other. So the really helpful thing here was that we weren't restricted by geographic location, so we were able to connect individuals even if they didn't live in the same city. We found this to be really key because PPA is relatively uncommon, and so it can be hard for individuals to, depending on where you live, to find someone else who lives in the same city who has this diagnosis. Some of the themes that came up during our support groups were their ability to cope with limitations and language decline. They found a sense of belonging. They were able to confront stigma, and we found that they were able to express resilience through this group. The picture on the left is different watercolor drawings that were done in an activity group that was for individuals with a diagnosis of PPA. So we had art sometimes, we brought in horticultural therapists at times, we played games, and we found that that was really powerful as well. So if you're looking for a support group, as was mentioned at the beginning of the webinar, the AFTD is a great resource for finding support groups that are located throughout the country. So now let's transition and think about speech language therapy. So there's research evidence out there that speech language therapy might be helpful, but it isn't something that has really caught like wildfire and been utilized for individuals with PPA as much as we would like. And I think that's due to a number of barriers. So the first barrier is a geographic barrier. So it turns out that there's few speech-language therapists with PPA intervention experience and expertise. And this is in part because primary progressive aphasia is uncommon, and also because the graduate programs for speech-language pathologists sometimes don't address dementia syndromes in the coursework, or if they do, they cover all of the dementias in a 1-hour lecture, including Alzheimer's dementia and other symptoms that individuals experience, and so they feel ill-equipped to help individuals with primary progressive aphasia. And so this can result in individuals saying there's nothing that I can do for an individual with PPA. We know that this is not true. If you find a speech therapist who does have this expertise, there's lots of things that could be beneficial. Because of this, there can be some low clinician referral rates. So if an individual is referred to a speech therapist who is not familiar with PPA, they may either tell the individual with PPA that they can't help them, or they may recommend some strategies that the individual finds unuseful. So the individual with a diagnosis will report back to the clinician that speech therapy is unhelpful. So this can create sort of a cycle of problems where the clinician will then stop referring. And then there can also be financial hardship. So some insurance companies, it can be difficult to get them to cover certain speech therapy services, or it may take a few tries to figure that out. And again, having more research about the benefits of speech therapy are something that will help change these things. Another challenge is that there's sort of limited information on the best practices in PPA. And again, that's because in part PPA is uncommon, so it's difficult to run big clinical trials to gain this evidence. Some of the individual variability that we see in PPA in initial symptoms and progression rate and the emergence of new symptoms makes it difficult to do this research at times. And then we know, again, that there's biopsychosocial considerations that may affect one's receptiveness to this type of therapy, or the therapy that might be best for them. So we're trying to overcome some of these challenges by running a research study to identify the most important elements of that are useful for individuals with PPA. And to get around some of these challenges, we provide the speech therapy through a telemedicine approach. So no matter where the individual lives, they have the possibility of enrolling in the study. And we provide them with a computer, and all they need is internet connection, and they connect to an expert speech language pathologist through video chat. So you can think of it like Skype or FaceTime. And then we're starting to think about, in our research, we're considering not only the individual living with aphasia, but how do these other elements play a role? So their language impairments, but their communication environment, their attitudes, their life situation. How do we best design a therapy to address all of those elements? And I have the word dyadic here, which just means that not only does the individual with primary progressive aphasia, not only may they benefit from speech therapy, but it's often useful potentially to have the communication partner as a part of those therapy sessions. So we're learning in what ways it might be most helpful to have that communication partner be a part of those sessions, because at the end of the day, communication doesn't happen with one person, it happens between people. So there's the idea that both the individual with primary progressive aphasia has changed the way in which they communicate, and so also the individual who is communicating with them may also need to change their communication style. There's different types of strategies, and I'll go through some practical examples of those next. They're binned into certain topics like impairment-based and compensatory-based and environmental engineering. So impairment is focusing on retrieving words and relearning things. Compensatory is more about bringing having a backup plan and maybe using a communication wallet or board. And environmental engineering refers to the fact that you maybe need to think about the environment in which you're trying to communicate. So trying to communicate in a loud, noisy room is likely not a good idea if you have PPA, and so moving to a quiet spot can be a way that you can communicate more effectively. We also built a web application, and we're investigating whether this will be helpful for bringing all of these tools together and kind of optimizing that therapy. So let's quickly go through some communication strategy approaches. So these are sort of more practical things that might be helpful. So if an individual has difficulty thinking of the name of this item here, there are two different types of strategies, impairment-based versus compensatory pathways that you could use. So impairment-based would say, let's put a picture, let's create flashcards to help an individual practice this word over and over again so that it will come to them more naturally in conversation. The other strategy would be to always have the name of that item in a communication notebook so that when the individual can't think of it, they just pull out that communication notebook and are able to kind of bring it up on the spot. So whichever way is most effective is, so both options are perfectly fine. And I want to show you how this has worked a bit in our research study. So this is a gentleman who participated in our research, and he was also a sheep farmer. And he was finding it increasingly more difficult to get out the commands for his dog Cookie, who is down here, so that the sheep would be directed in the right direction. And so these over here are the communication flashcards that we worked on with him so that he could still herd those sheep. We had another individual in our research study who liked to go golfing with her friends, and so she could still stay socially connected with those friends. She wanted to be able to talk about her golf swings more effectively. So this is an example of a flashcard that she created, a communication card that she created and practiced and then had with her if she needed it. A question that can come up for care partners is, if my loved one is having difficulty thinking of a word, should I fill it in? And so these are sort of the things that our speech therapists would recommend. Is that first and foremost, it's up to your loved one. So talk with them and ask them, do they want you to fill in the word? Do they want you to fill in the word in certain situations but not others? And just some reminders that it's not going to make the aphasia worse if you fill in the word, and it may help with anxiety. And that the ultimate goal here is for you and your loved one to be able to move on with the conversation. Another strategy that can be helpful is script practice. So by repeatedly rehearsing a script, you can improve the automatic access to those words and make phrases more fluent. There are different types of scripts that might be used for phone calls or telling jokes or stories, prayers. I've shown a couple here. Is one where an individual was practicing the Lord's Prayer, which was really important to them. And then another person who wanted to practice their fast food order so that they could go to the drive-through and order independently. Some individuals want to practice a script about explaining their diagnosis. This individual had a little sense of humor about it. So if you'll see, he says, I'm losing my words. It is a relatively rare neurologic condition called primary progressive aphasia. My speech has slowed down. I have to plan out each word, one syllable at a time. PPA only affects my speech, nothing else. It does not affect my mind and intellect. My good friends say that an attorney without words is a real blessing, so bear with me. So this individual has kind of personalized their script about telling others, and there are cards that are more standard that are available either through our center or others. And there are different ways in which these scripts can be personalized, or you can put them on business cards and bring them with you so that you could hand them to a taxi driver or use them to read from if you're in daily conversation. Communication wallets and boards are another useful tool. We would call these a compensatory tool used to help communicate. So you might have these digitally on your phone, or you could post them in your house, or you could create one that comes with you so that you can communicate more easily. Another example is using it to manage medications. This bottom example is a smaller, more portable one, and it's actually laminated card so that you can write on it with dry erase markers. We talked a little bit earlier about modifying the environment to improve communication success. And so eliminating distractions are some good examples of turning off the TV to help with that communication. And there's a few others up here. We found that some individuals who have difficulty talking on the phone may do better if they're using some video chat program, something like FaceTime or Skype. Thinking about the way that the care partner or the communication partner is speaking can also be helpful. So simplifying sentence structure, slowing down one's rate, and increasing the use of nonverbal cues are other ways that might be helpful, or using written or picture cues are other examples of useful strategies. So we've talked a bit about how other symptoms may emerge with time, and those can also, speech therapists can also help you with those symptoms too, so they can be equipped to do that. They may help you set up stations in your home with big clocks that tell the day and date and time, so to have visual cues for individuals with memory challenges, or creating schedule boards to remind the individual about the daily schedule. There are more high-tech options that can help with medications or other needs, and so these are just a few examples. Other individuals may need strategies for challenging behaviors, and so I'm just going to list those up here. We don't need to read through all of them, but these are commonly focused on working with the communication partner, the care partner, to help diffuse situations and avoid getting in arguments. So redirecting is a really useful way to do that. And here's a practical example of how this has been used by some of our clinicians. So if there was a gentleman with a behavioral variant FTD who the challenge was the individual was only showering once every 3 weeks. And so the solution was to create a smartphone video of his neurologist reminding him to shower. So, Bob, this is your neurologist, Dr. Memon. You really need to take a shower every day so you don't develop a rash. You'll feel much better. And so the care partner would play this video for the individual, and they found that the individual was very receptive to this video and wanted to listen to their doctor, and so began showering 1 to 2 times a week, which was much improved over the previous amount with this strategy. So that's a lot of information very quickly, but I wanted to give you a few practical ways in which there are things that we can do today that might be helpful. And mostly just thank you, and thank all of my collaborators, and in particular our participants for their time and commitment to research, and also our funding agencies. So thank you so much.
Emily, thanks so much. And you're right, we've gone through a lot of information with your help today. We have time for a couple of questions before we truly wrap up. And so a couple of people are really interested in speech therapy and its role in assisting people with primary progressive aphasia. Can you, you defined PPA as a progressive disease. So can you just speak for a moment about, what's the advantage of a therapy given that the person is unlikely to be able to retain the new techniques over time as the disease progresses?
Oh, I'm so glad that this question came up, and I should have mentioned it earlier. So we think that ideally speech therapy isn't something that you graduate from, but is a service that you would use for a period of time and find a set of strategies that work for you at that time. And then eventually, because this is not curing the disease, eventually there may be the emergence of new symptoms or there'll be a change. And at that point, we would urge you to reach back out to your speech therapist, and then they would work with you to identify a new set of optimal strategies given your new strengths and challenges. So this would be sort of an iterative process rather than you go to speech therapy for one set of sessions, graduate, and never go back to see that clinician.
And I think that a related question was, you know, is there an optimal time to start speech therapy, or is there a time at which it's too late to start speech therapy?
So we're still, I personally believe that you should start early so that you can start to get these tools and strategies in place and prepare for the future and really understand how to optimize and understand what's going on. But it's never too late in that there's speech therapists are skilled in providing strategies to really help individuals optimize their strengths and challenges in each and every setting.
Well, and I thank you very much. Unfortunately, the clock has run out for us. So I want to take this opportunity to really thank Dr. Emily Rogowski for her presentation today and for generously jumping in and helping with all the questions that we have. I want to thank all of you for joining us and for taking the time to spend with us to learn more about PPA. There were a number of questions we did not get to because of the time limits. This is always the case. If there are burning questions that you want to float with our helpline, you're welcome to send them to us that way. We'll do our best to answer them and get back to you that way. I do also want to remind people that we are recording this session, and so it will be posted here where you see it on our website under the section that's called What's New. There's a section for webinars. That's where you'll find this one in a number of days, as well as all the previously recorded webinars in our series. And as always, we encourage you to let us know if you have comments or questions about today's presentation or suggestions for things that we might cover in the future through this format. So once again, this ends our presentation, and I thank you all for spending time with us today. Have a very nice holiday season.